This episode is brought to you by CDW Healthcare. CDW understands how to connect the latest technology solutions and services to advance your healthcare mission while keeping patient and staff at the forefront. Whether you're looking to upgrade your EHR, redesign your infrastructure, improve care delivery at the bedside, or elevate the home health patient experience, our dedicated team of industry-tested experts leverage software, hardware, and comprehensive services to orchestrate cost-effective solutions that leads to positive patient experiences, higher quality care, and more efficient clinical workflows. For more information, check them out at thisweekhealth.com/CDW. Today on Keynote.
We got to deal with it because the country's not getting younger, and managing people proactively, primary care, that's what other countries do. And we can either do that or we can take care of sicker people in the hospital.
My name is Bill Russell. I'm a former CIO for a 16-hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Our Keynote show is designed to share conference-level value with you every week. Now, let's jump right into the episode.
Welcome to Keynote, and I am honored to be joined by Dr. Joel Klein today from University of Maryland Medical System. Amazing career trajectory, and is noted for his transition from an emergency room physician to a leadership role within healthcare IT, where he now sees system-wide initiatives such as Epic implementation, cyber and IT infrastructure. And Joel, you've got over 29,000 employees across 14 hospitals, which in and of itself is amazing, and working to make sure those IT solutions meet the needs of providers, patients, and reducing administrative burden. So thank you for being here and welcome to our Keynote show.
Thanks a bunch. It's a pleasure to be here. I really appreciate it.
Of course. I'm going to start with a pretty broad question for you, and that's how your experience as a physician has shaped your approach to leading healthcare IT.
Sure. Being a doctor and then moving into something like IT means I started out as a customer. Working in the emergency department for all those years meant that I had to use the computers and the phones and the faxes back when we used faxes and all of the applications on the computers. And so I know what it feels like when the computer or the programs or the EMR or whatever it is doesn't work well or at all. And so I think that has a little bit of a fire for me about making sure that the IT team understands this is really how important this stuff is for everyday folks. And there's the whole story of how I went from one career to the other and how the skill sets translate. But I think from a pure passion point of view and wanting to get it right on behalf of all my fellow clinicians out there who depend on this stuff, yeah, it was pretty motivating.
When you shared in some of the conversation we had prior that in that shift to making a career change, that everybody is scared of something professionally. When you think about that from the perspective of a physician and now a CIO, what comes to mind?
Yeah, all the time I would show up for a shift in the ER and I would be doing what is called sign out. So that is where the doctor who's going home tells the doctor who just showed up, in this case me, here are the patients that I need you to take over for me because I'm leaving and you're now taking my place. And in some cases, the patients had already been all figured out and worked up and there was a good plan for them. But in some cases, my partner might not have figured out what was going on. And now I need to pick up the ball. And in some cases, I have to start all over again because what they were doing either didn't make sense or they weren't looking at it correctly, or you always help each other out. And there's always, because what goes around comes around, and I'm certainly going to be the one giving someday. And so it's a collaborative kind of process. But what you start to notice over time is that there are some people, some doctors, some NPs, some PAs, and I'd say this is true for everyone. It's true for a respiratory therapist, it's true for nurses, it's true for all of us. There's some kind of patients that we don't like. Either we just don't know the medicine well enough, or we had a bad experience with a patient like that a long time ago, or we forgot what to do, whatever it is. Or we're just generally super conservative and you're scared of everything. And so what happens is you see people start to act super defensively and order lots of tests. And I ordered all these tests and now you figure it out. This is something that starts to become a pattern for some people. And even for the rest of us, there's always a disease or 10 diseases or certain kinds of patients that you just you're afraid of. You see them roll through the door and you just get this pit in your stomach that, oh God, I got to go deal with that. And like I said, sometimes it's a knowledge issue. Sometimes it brings back memories of a terrible situation you were in, whatever it is. And you've got to figure that out for yourself. Everyone's got to tap into that and be honest with themselves and reflective about it and go figure out how you're going to deal with it because it's going to come through the door again. So for me, I would say a big one, strangely enough, was nosebleeds. That was always something that I just didn't like to deal with. I had a few terrible cases early on in my career. And just the prospect of what am I going to do if I can't get this bleeding under control? Whenever I saw when I picked up a chart and that's what it said, I would always think, oh God, here we go. And so the way you deal with that is you have a plan, right? You go back, reread the book, go talk to your colleagues and say, I'm going to do these 5 things in order, and this is how I'm going to manage it. And the 6th thing is I'm going to get help. And when you have a plan like that, you start to feel more comfortable and more confident in your own ability to manage a problem that still might make you a little queasy, but at least you have an approach to it. And when you're in charge of IT and you get a phone call that everything is down, or the computers say, pay us 10 billion Bitcoin, or whatever these calls that we get in the middle of the night, same reaction. Like you're going to get that feeling of, oh no, the day has finally come. And that's where you fall back on your training. You fall back on, we had a plan somewhere. Where's my plan? We practiced this. We talked about it. Everybody's got a job. Everybody's got a role. And let's just launch into that. Whatever it is, we will get through it, just a bad nosebleed. And being honest about the fact that I don't feel ready for this, or we need to talk about this some more because I don't feel like we have it together on this. That can be a super motivating, super galvanizing way to get organized around stuff that we're responsible for.
When you think about the grit that it takes to be a successful ED physician and to be able to methodically think about, I'm going to triage this patient in this manner, how have you found that translating over to crisis management with your team, whether it's your IT team, your C-suite peers, heck, even talking to the board, knowing that you can handle this? There's a way to think about it. There's got to be a level of appreciation for your background now dealing with the executive and technology side of the equation. How well has that worked for you? And what are some big takeaways being on the other side of it now?
Yeah. So it's the same job. I'm telling you, there's almost no difference. So when I started after residency, I got hired at a community hospital where I was the night guy. So there's not a lot of help around. And I will never forget, they brought me like an 80-something-year-old woman and she was having some trouble breathing. And when you're 80 and you're having trouble breathing, there's half a dozen common things. And they're all managed a little differently. And she was really sick. So we got her intubated and put on a ventilator, a breathing machine. And then we started doing the things you do to figure out, okay, is it pneumonia? Is it heart failure? What is it? Before I knew it, somebody let the family back. And it was the husband and a couple kids, like adult children. And where's the doctor? What's going on here? What is wrong with her? Like right now. And so the staff came and got me and I went in there and I said something like, we're not sure yet. We're working on it. We're doing all these. And he just cut me off and said, you need to tell me right now. It got really heated. And again, I was right out of residency. I had never managed an upset person before. And of course, I was still finding my own style and trying to get my own confidence as a new attending. And I had to extricate myself and collect myself. And I ended up calling one of my colleagues in the IC. Can I just go over this with you to make sure I'm not crazy? And then I eventually went back in there and managed the situation. And I've been in circumstances now in board meetings where something goes completely sideways that you didn't think was going to be a problem. And you suddenly realize that the board chair is making a valid point. And you hadn't thought about this. And your CEO is looking at you like, this is a problem. And so the only way out of that, again, just a super sick person, is you got to collect yourself. You got to pick up the pieces and say, all right, here's what we're going to do. 1, 2, 3, 4, 5. Let me come back to you and we'll fix it. There's 3 options and one of these is probably going to end up making sense. And as long as you come back and do that and actually follow through on what you say you're going to do, and it does make sense, then all will be well, just like it was with that patient. But it takes time, it takes experience. but it's the same job. I'm telling you, there's tons of careers where you have to do things like that. But certainly for me, I have found them to be remarkably similar jobs.
That's an incredible perspective. Thank you for sharing it, because not many people go from being a practicing physician or remaining a practicing physician and then head into the executive side of the equation. When you are coming up through the ranks as an executive, as a junior executive, you don't really get that kind of training. Those are those, oh my gosh, on the job moments that can sometimes make or break your success within an organization. And so having the experiences that you do, how do you teach that type of resilience and that thought process to your non-physician executives?
Yeah, so I think if there's one thing I've tried to tell people is just say yes and just help out. So my administrative start happened when I was standing in the emergency department and somebody called the secretary with a complaint. And it turned out it was an ophthalmologist in the community who wanted to yell at someone because one of my partners had given out a bottle of tetracaine, which you're not supposed to do because it can numb up people's eyeball. And then when dust or something gets in their eye, they won't blink it out. And it can cause you to really damage your eye. And I guess one of my partners, somebody had a corneal abrasion or something, and they thought it would help them feel better, which might be true, but it's still not a very good idea. So he wanted to complain about this. So I wrote it all down and I went into my boss and said, I just took this phone message. And my boss just looked at me and said, okay, we'll go deal with it. And I had no idea what that meant. And he said, go find the guy who gave it out and talk to him about it. So that was my first patient complaint. And hundreds of those later, I didn't ask to do that. You just follow through and do it. And whether it's fundraising for your hospital or serving on some committee or giving out ice cream cones or whatever it is, if you just do it, people start to think of you as someone who is willing to help. And I can tell you in IT, that's like the coin of the realm. If you have a reputation as someone who is willing to lean in and take a meeting about whatever crazy problem we've come up with today, even if you can't solve it, people will see you and know that you were there and you tried and you were at least were willing to give it a shot or at least have a few thoughts about it. And that's the reputation you want. And that's what great leaders do. And if you just say yes, if you just lean in, even if it's got nothing to do with you, nothing to do with IT or whatever it is you do, that's how you get noticed. Just say yes to stuff.
I love that perspective, because you now have this dual responsibility of ensuring that the IT solutions that are being implemented to a degree remain user-friendly for clinicians while still managing the cybersecurity elements. Like you mentioned, the phone call in the middle of the night. How do you ensure that balance remains in the organization?
Yeah, that's something all of us have to deal with. And we all have a set point. We all have our thermostat of where we are willing to set risk tolerance. And I think when you've had to actually walk the walk in a clinical space, you're going to set it maybe a little bit differently than someone who's never had to do that. And I think whether it's cyber risk or just decision making in general, I think people who have taken the time to spend a shift or a week or a chunk of their time in the clinical space, even if that's just consistent rounding, you're going to make decisions that are more aligned with what the business is trying to do. And yeah, that might mean taking on more risk, or it might mean not just cybersecurity risk, but other kinds of risk as well. But you at least are doing it knowing what the troops need and what the patients need and what their families need. And if you say, you know what, I know they need this, but we can't do this, then you're going to have the credibility of someone who's actually lived it, or if not lived it, is pretty aware of it because of the time you took to go and see it or experience it. So it'll help you make better decisions. It'll help you think about all of the choices that we have to make. And they're not always binary choices, right? One of the things we're struggling with right now is how many minutes should it be before a workstation hibernates or locks or whatever before you should have to log back in again. We have it set to some number of minutes. And there's a debate going on about right now about whether we should cinch that down, or actually there's other people who say, why can't we relax it a little bit under other circumstances? And that's literally a thermostat. That's a volume knob of, are we going to turn it up or down? And it's not like there's any Bible about how to do that. But if you've spent time running between a patient room and a desk and running back and back and back, you're going to think about that differently.
We recently covered an article about, does healthcare IT have too many pilots? There was a joke about hospitals have more pilots than airlines. And as you think about that, they know that you're going to go and round, or that you have a perspective on what it means to practice medicine. And yet you still have to keep innovation going. You still have to be thoughtful about the technology you're bringing into the facility. What does that look like from your perspective when you think about being able to meet people where they are, being able to introduce new innovation, and still scale that potentially across multiple facilities? What are some of the challenges, but also some of the wins that you've experienced?
Yeah, so I have fairly strong opinions about that, but they're not maybe what you would think. They're in both directions. There's a lot of people in IT who refer to pilots as the good idea fairy. And the way I've had to explain it to a lot of my operational colleagues is we've got 14 hospitals, and if all of them want to do 3 pilots, I just bought myself 50 new projects. And when you put it that way, you realize, okay, yeah, maybe this isn't such a good thing. But on the other hand, you are absolutely right. And I think the whole amazing set of things that's happening now around Gen AI really has brought this into sharp relief. If we don't get out there and try stuff, then man, are we getting left behind. And I don't just mean as one healthcare organization within the industry as an opportunity to help take care of our patients more constructively. We've got to try stuff. And so there's a bunch of things you can do, stopping a pilot early if it's clearly not going where you want it to go. I think having super clear endpoints, which you can change them later, you can move the goalpost, but you got to have something. It shouldn't just be Mikey likes it versus Mikey doesn't like it. And I think having governance around it, right? It can't just be Bob saw something at a meeting and now Bob gets what Bob wants, because that's how it works in a lot of places. You've got to have the right eyes on these things so that you're not putting a whole bunch of effort behind something that's never going to work. And then I think talking to your peers, if you hear that 5 other places near you or like you, they're all piloting this and they're all, yeah, this kind of feels right, then go for it. But if no one's ever done this before and it sounds completely crazy, again, I'm not saying don't do it, but again, put your thermostat in a different place about where you ultimately want to come down on that. But we got to do it. If we don't do it, it's a mistake.
When you think about, to your point, hey, let's do 3 pilots times 15 or 16, and that would be the entire capacity of your team minus keeping lights on and other aspects. But you are breaking ground on a new facility. You're doing a replacement for rural care, $540 million in Easton. And what I love about that is it becomes a playground to a degree for you to put the existing things that are proven, but try out some of the newer technologies. What kind of a foundation does a brand new facility give you in that ability to try something that maybe hasn't been launched anywhere else in your system?
Yeah, we're super excited about this new hospital. The place that is there now, this hospital in this, this rural town on the eastern shore of Maryland, the IT storage closet is right over the helipad and the roof leaks. So you go in like to get, a spare monitor or something, and there are tarps everywhere because it rains in there when it rains outside. It's ridiculous. The community really needs a new hospital, and we're really excited to have broken ground on that. You're absolutely right. There is a ton of excitement for us around all the things that we're going to be able to bring to bear. And a lot of it has to do with the refinement of what telemedicine looks like in what will be 2027, I think is when it will open. So we know what that looks like today, and it's wired telemedicine setups, not just for remote consultation from our tertiary care center into any room in the building, but remote nursing as well. Family visits, pastoral visits. We'll end up doing, I'm going to guess, remote social work, remote patient placement for post-acute services. All of that stuff is going to be possible. Now, depending on where we are on the telemedicine journey, those rooms are going to be kitted out properly with all of that stuff working amazingly well. We're really excited to do it. We've got a small innovation team within IT whose roots are in clinical engineering. And they're the guys who love trying to wire up TVs to cameras to the Code Blue system to whatever else they can find. And that's the team for us that I think will have a ton more to show by the time we get the building open. And I guess I'd add one other thing, and that is for those of us who have done new hospitals, we did another new one about 3 years ago. It's such a fun, amazing, exciting. When you open a new place and you've got to transport 300 patients in one morning, and put all new hardware in there and test it all and make sure it all works. And when you've put Epic in a whole health system, you get really good at technical dress rehearsal and all that stuff. And it's just an opportunity to showcase the whole team to do what they do so well, which is roll this stuff out. They've gotten really good at it. And we're really looking forward to it from an IT point of view, but also because of what it will mean for that community.
When you think about the high point, the energy that comes with that type of endeavor, the excitement, and the fact that maybe those first few weeks or months that the conversation isn't about burnout or capacity or other issues, how can you take something like the opening of a new building that's serving a community, a whole new hospital, to addressing clinician burnout with the help of technology? Where do those two come together with something like what you're building in Easton?
Yeah. So I think when you empower people to make decisions, getting control over your environment, we know is a critical piece of how to manage burnout in a constructive way. It's when people start feeling powerless and that they're just being blown around by the wind of their work. That's when burnout really can take hold. And when you can all get galvanized around a common goal, it can be transformative. For us, and I know this is true for so many people in our industry, COVID was such the example of that. So we are one of the health systems that did a ginormous field hospital. Ours ended up having a pretty decent census for most of the time that it was open. It was in the Baltimore Convention Center, which we did with the Army Corps of Engineers. It was one of these vast places that has just endless rows of beds and our Epic stuff and our wows and our telephones and our printers and all that stuff in there. But then okay, now can you stand up a monster vaccination thing in an NFL stadium? Or we found another big parking lot over here. Can you have that done tomorrow? The kinds of things that under peacetime conditions, people would say, no, we can't do that tomorrow. But under what we all went through, people were just willing to do it and really go the extra mile. Now that we're past all that, finding ways to give people input and say and an opportunity to participate in a project like this, it gives people hope. It gives people something to really rally around. And burnout continues to be such a huge challenge in our industry. And so, and especially in a community like this Eastern Shore, where the burnout isn't necessarily different, but recruiting for staff like nurses is a huge challenge just because of the inherent geography. Offering more structures for things like telemedicine, more opportunities to care for patients remotely, whether you're a doctor or a nurse. Those are all things that we want to try to empower, again, to keep people going in the profession so that we can keep them, again, as part of the team and take advantage of all of their experience.
So if you think about being able to put new technologies in place that the people that are going to be at this new facility, and I imagine a significant amount of the people that will be working at the newer facility are at the existing facility. And so to your point, when they can walk in the building and the roof isn't leaking or there's not cracks in the walls. And I used to work at a county hospital where I literally would not wear the clothes into my house that I wore to work because you just didn't really know, even exposed to or experienced in those given days. It is a more rural area. And so if you have to think about interoperability and data sharing and getting the confidence of those clinicians and that community, what are some of the things that you have to face and be thoughtful of as you open a new facility with the newer technologies?
Yeah, so that's actually a really interesting problem in this particular part of Maryland. So you have obviously our organization, which has many ambulatory practices, some primary care, some specialists. But then there are a fair number of other kinds of doctors who are out in the community in their own office, in their own practice, and they don't have our Epic instance. They don't necessarily want that kind of infrastructure. They're very happy with what they have, thank you. But we want to make sure that we can let them know what happened to their patient when they were in the hospital. How do I get a discharge summary? And we're really fortunate that in Maryland, there is a robust health information exchange that makes all that kind of thing possible. And we are one of the part owners and of that exchange and sit on its board of directors and certainly provide a substantial amount of funding for it. But it doesn't change the fact that we still have to have dialogue with these practices. We still want to be available, for instance, to do lab work for their patients, radiology studies for their patients. And so building plumbing essentially between our infrastructure And whatever it is that they're using in their office is still something that we have to do. And we have to do it respecting whatever resources they have or don't have to make it work for them, because in most cases, they're not going to be able to change what they're doing. And so we need to be able to meet them where they are. That's the expectation of us as an anchor institution in that space. So it's a huge challenge, but again, it's gratifying when you realize you've made it work and you get the positive feedback that, yes, this is exactly what we.
So when you have that increased access, you have increased equity, you may even have increased availability of information. How do you also balance availability of getting an appointment, as an example? Because you can open up more beds, you can open up more locations, and yet being able to actually get an appointment in a timely manner. How does opening new facilities and working with these other entities open up that capability for a patient as well?
So that's a huge issue. When we built our last hospital, University of Maryland Capital Region facility, which is in, if you think of the DC Beltway as a clock, it's around the 3 o'clock position right off the Beltway. It's in Prince George's County, another underserved area from a medical point of view. Also had a falling apart hospital that had decades of management issues and underinvestment. And we acquired, or I would think it's fair to say they joined our organization. And part of the plan at the time that they joined was that we would build a new hospital. And so we did that. And it's an absolutely gorgeous facility. And utilization has gone way, way up, and we can't meet the demand. And there's a whole nother side to that in Maryland because of the way hospitals are reimbursed in Maryland. If our volume goes up, we don't actually get any more reimbursement at all. No, our net income from patient care operations stays exactly the same. So it's actually a disincentive for us to build a gleaming new facility to take care of people who really need the care, because then when they come, we get, it's not 10 cents on the dollar, but it's some version of that. And so we're going to have to contend with a similar thing as we build this new facility. And I think the other piece to this is outpatient access, starting with primary care and all four corners of primary care, family practice, geriatrics, pediatrics. You can't get an appointment. And that's before we start talking about cardiology and all the specialists. We've got a problem. And I think this is a national issue. It's not something that any one health system, I think, is responsible for solving in isolation. This is something that we as a country have to figure out. And some of that comes back to reimbursement. Some of it comes back to what it's like to practice in those specialties and the choices that people coming out of medical school with $500,000 in debt, the choices that they have to make economically. Venture capital has a role to play here. There's just so many dynamics, but we got to deal with it because the country's not getting younger, and managing people proactively, primary care, that's what other countries do. And we can either do that or we can take care of sicker people in the hospital. And to me, a no-brainer, but it's obviously super complicated.
You bring up the aging population aspect, especially the geriatric care, and what you may have heard coined as the silver tsunami coming our way, with the next 20 plus years being the largest influx of senior care that we'll ever see in this country for multiple generations to come. When you think about automation and you think about the ability to put things in place that allow for what is coming, how are you balancing the expectations and even the budget implications of what it means to prepare for 2030 when the massive amount of boomers really are going to hit your doors in a more acute manner?
Yeah, I think it's a little tough at this stage to say that automation is going to solve that problem. We need a workforce. We need a competent, experienced workforce that has pipelines that can take somebody at the start of their career and accommodate the mentorship and continuous learning they're going to need to be a senior nurse or an experienced surgeon or what have you. We have to do that. And we're not going to do it if we keep going the way we're going. Because you're right, we're going to have more folks to take care of than we'll be able to. And there are some people who say that the emergency departments are the canary in the coal mine of what that's going to look like in a given community. And that can be really scary. We've got to figure this out. I know in our organization, our chief nursing executive, the amazing woman named Lisa Rowan, and our new CNE, Peggy Norton-Roscoe, they are working incredibly hard to forge partnerships with community colleges all around the state And it's not just finding people who have decided to go to nursing school and getting them into our organization, come do your rotations with us. What we've got to do now is start thinking about, okay, how do we actually show people who didn't even consider nursing what an amazing career this can be, how rewarding it can be, and how fulfilling it can be. And so how do we get people exposed to all that? And we could be talking about high school at some point. We've got to get the workforce. That's the whole nine. That's the ballgame.
It is. And you wrote an article or a perspective a few months ago about aviation. And I'm curious from your perspective, as you bring up these junior ranks, how can healthcare teams implement strategies from aviation to ensure that the newer entries or the junior staff, they feel empowered to not only speak up during critical situations, but also help plan for the future in the scenario that you just described?
So aviation for me is a little boy thing. I've always loved airplanes, and I probably would have become a pilot if I wasn't afraid of heights. It's such an amazing industry. So I guess there's a few things I'd specifically point to. One is this whole idea of what the high reliability community calls standard work. In an airline, there is the standard work of briefing a departure. This is how we're going to taxi out to the runway. This is the power setting we're going to use when we apply takeoff thrust. This is what you're going to call. This is what I'm going to call. These are the circumstances where we're going to stop the takeoff. They talk about that on the first flight of the day. These two people are going to go through this. And I can tell you that when you go to intubate somebody in the operating room or the emergency department, you don't say, here's what we're going to do. You're going to hold the stylet. I'm going to hold the suction. When I go like this, you're going to hand me the T-tube from the vent. There's none of that. That's not part of the culture. It's not part of the expectation. When somebody gets their appendix out, there's a timeout in the operating room where we talk about the right patient, the right site, the right allergies, all that stuff. But in a lot of places, full attention to that is not the same. And it's maybe the superficial details of the case, not how I'm going to do this appendectomy. We don't get into that in the same way that the professional pilots do when they talk about how they're going to conduct their operations. So that's one big thing. The other big thing is training. And I find that so fascinating because training for clinicians of all stripes, that's a sacred thing, right? Going to medical school, the whole ceremony of all of that, everything that we go through. But then I think it really diverges from there. I think there are parts of our industry where continuous training and a commitment to know we're going to bring people in and pay them 8 hours to do in-service on all this new equipment that we have, it's not what it should be. And when you compare that to you have to do all this simulator training where we're going to do upset training where we're going to take the plane and flip it over and have it heading straight at the ground and you have to recover from that. That's not something that's done everywhere in clinicians of all stripes. The expectation culturally is just very different. And that's something I think we can all work on. It's something where technology clearly has a role to play, both in just presenting information, PowerPoints, or learning management systems, but also more sophisticated things like simulator training, randomizing results, and even using things like Gen AI to create situations and scenarios that we ask people to respond to, either when taking a history or here's a situation, how would you deal with it? All of those kinds, lots of opportunity. But I think we as an industry just have to commit to that.
Yeah, we've seen the ability for now augmented reality to start to train both clinicians in these scenarios, patients for something like infusions when they're going through cancer treatment, and really giving people almost like an alternate sense of ability to absorb and retain the information in a way that could be safer than the actual real-time experience. And so that's an amazing perspective from the airline industry into medicine. And yet you're also a musician. And so if you think about how you balance just honestly the stress that comes with what you do every day, how does music play into that for you?
Yeah, I used to have an acoustic kit back here, and then COVID happened, which meant everyone was in the house. So this was my way of trying to be quieter for my family, which they appreciate, although I do sometimes turn that amp up all the way. And then I've got a keyboard over here that I also play. I don't think of it so much as stress relief. I just like playing. And I'm right at that point where I need to find other people to play with, or I'm not going to get any better. I think I sound great down here, but I'm right at that stage of development where if I don't like gig with other people, this is going to be as good as it ever gets. So yeah, I will turn up some Van Halen or some whatever it is, the Cure or whatever that I happen to be listening to that day, and pretend that I had yet another alternative career.
I'm sure that people listening to this episode may reach out to you and say, hey, I'm a bass player and I need some help, or some friends as well. And then you're going to have the other guitarist that shows up. And pretty soon there's going to be the Joel Klein rock band as an output from your latest keynote interview.
That'd be pretty sweet.
It would be pretty
I
sweet.
have a basement.
We actually have one of our partners plays in a metal cover band. And one of the things he said recently was, man, if you get Van Halen wrong, the crowd goes nuts. They'll start yelling, at you, you missed that riff. And he was like, I never thought people could be so passionate about a certain way music is played.
So I am a pretty big Van Halen fan, and I actually agree with that. I don't think you should try to cover Van Halen songs unless you're going to do it in a unique and interesting way. Actually, there's an amazing bluegrass album that is a bunch of bluegrass covers of Van Halen. If you want to do it, that's how you do it. Don't try to copy Eddie, please. It won't work.
I think I'm going to go find the bluegrass covers because, yes,
so good.
It'd be good. It's a new perspective as well.
It's called Strumming with the Devil.
Strumming with the Devil. I'm going to add that to my mix. And this is picking up good music ideas. In fact, Van Halen was one of the bands who, in their contracts, would specifically put that they didn't want M&Ms. And if it was there, they realized that it could be a risk or safety factor. And you think there's always just so many corollaries that fit into our world today. I tend to go through and actually read a full contract now before I just assume that I know what made it.
Okay, so the Alex Van Halen YouTube clip where he explains that is hysterical. Because he tells stories very well, and he talks about how the stage sunk into it's look it up. It's fantastic.
I will, and our production team will put into the show notes
please
bluegrass reference and that clip to that YouTube video. I'm going to have a couple fun speed round questions in for you because I appreciate the depth by which you share your expertise. And then I think it's always fun to get a little bit inside people's heads outside of a boardroom perspective. And what is one book everyone in healthcare should be reading?
House of God.
Okay.
Samuel Shim.
If you weren't in healthcare, what would you be doing? If you weren't a pilot and you're not a musician and you're not a doctor, gosh, what else would you be doing, Joel?
Yeah, I'd be working in a restaurant.
Any particular favorite food that would aim you?
Yeah, you have to either be a pastry chef or a line cook, and I'm probably more of a line cook.
Yeah, I probably would be too. Actually, I'd be the dishwasher. That's my role in my house now, and I'm actually pretty good at it. So that would be my entry point. Describe your job in 3 words.
How about just whiplash?
Compound word. Good one. Last question for you in the speed round. What's one technology you can't live without? The phone.
The phone, yeah. And it's funny, I was at an amazing meeting. It was hosted by a venture capital firm out in California. And somebody there was talking about how we went from the vacuum tube computers to the mini computers to desktops and then now to this. And his quote was something like, "Is this the best we can do?" And everyone was like, "No, it shouldn't be. Of course we could do better than a phone. What does that look like?" And so it got everybody thinking about what the next form factor might be. And I don't mean a folding phone or a folding screen, a Minority Report, stuff in the air, or something truly crazy. Whatever that is, I think having it at my fingertips I will have a seizure if it goes away.
For sure. You saw Google Glass had its moments and some trying out, but now during the World Series, pictures of Ray-Ban with Meta, and it's all presented right there in your glasses. So I'm already wearing contacts, so I imagine if the phone gets any smaller, I have to rely just on that. But if it's displaying for me somehow in a heads-up view from your contacts, they're doing all these experiments with the astronauts and measuring the impact of being weightless for a period of time. Maybe it gets there in time for us to hit that silver tsunami. We'll wait and see for sure.
It'd be awesome.
Yep. Thanks as always for your time, your perspectives, what you give back to the community, the support of 229 and This Week Health. We appreciate you, and we look forward to continued conversations and summits with you.
Thanks a ton. Great talking to you.
You too. Take care.
Thanks for listening to this week's keynote. If you found value, share it with a peer. It's a great chance to discuss and in some cases start a mentoring relationship. One way you can support the show is to subscribe and leave us a rating. Love it if you could do that. Thanks for listening. That's all for now.